Good morning, all of you. My name is Khushboo Gupta. I am Associate Professor in IIMT College of Pharmacy. The topic of my presentation today is drugs acting on respiratory system and gastrointestinal tract. These are the drugs we'll discuss in this unit. The drugs used for bronchial asthma, pathogenesis involved in asthma, types of asthma, classification of asthmatic drugs, pharmacological actions on central nervous system, pharmacological actions on cardiovascular system, adverse effects, uses, chronic obstructive pulmonary disease, the drugs used for COPD, drugs used for cough, and the classification of expectorants and antitussives. Now, first we'll discuss about drugs used for bronchial asthma. It is characterized by hyperresponsiveness of tracheobronchial smooth muscles to a variety of stimulus, which results in narrowing of air tubes, which is often accompanied by increased secretion, mucosal edema, and mucous plugging. Their symptoms are dyspnea, wheezing, cough, and limitation of activity. The pathogenesis involved in asthma is now recognized to be an inflammatory condition, inflammation underlying hyperreactivity. It is an allergic basis which is demonstrated in adults and higher percentage of pediatric patients. In other, a variety of trigger factors are also there, such as exercise, exposure to cold air, and psychogenic factors are also involved. Now, the next types of asthma. The types of asthma are extrinsic and intrinsic asthma. Extrinsic asthma is episodic. It is less prone to status asthmaticus, and intrinsic asthma is perennial. That means it is not episodic. It is more common. In this, the mast cells present in lungs and inflammatory cells recruited as a result of the initial reaction which produce a multitude of mediators. These release of these mediators stored in granules are histamine, protease enzymes, TNF-alpha, release of phospholipids from cell membrane followed by mediator synthesis, that is prostaglandins, leukotrienes, activation of genes followed by protein synthesis, interleukins and TNF-alpha. All these factors are involved in intrinsic asthma. Now the classification of drugs, first bronchodilators, that is beta-2 sympathomimetics, salbutamol, terbutaline, benbuterol, salmeterol, formoterol and ephedrine, methylxanthines, theophylline, aminophylline, choline theophyllinate, hydroxyethyltheophylline, theophylline ethanol of piperazine, doxyphylline. Anticholinergics, ipratropium bromide, tiotropium bromide. Next are leukotriene antagonists, that is montelukast and zafirlukast. Mast cell stabilizers, that is sodium cromogylate and ketotifen. Corticosteroids, that is systematic hydrocortisone, prednisolone and others. And in inhalational, beclomethasone dipropionate, flunisolide and cyclosonide. Anti-IgE antibodies, that is omalizumab. Now the pharmacological action on CNS is the caffeine and theophylline. These are CNS stimulants which affect the higher centers. Caffeine in the dose of 150 to 250 mg reduces a sense of well-being, alertness. It beats boredom, allays fatigue, thinking becomes clearer, even when dullness has tended to prevail after sustained intellectual effort. Action on cardiovascular system. They directly stimulate the heart and increases force of myocardial contraction. They tend to increase heart rate by direct action but decrease it by causing vagal stimulation. That is, the net effect is variable. Tachycardia is more common with theophylline, but caffeine generally decreases heart rate. Cardiac output and cardiac work are increased. At high doses, cardiac arrhythmia may also be reduced. Now the action on smooth muscles. All the smooth muscles are relaxed and the most prominent effect is exerted on bronchi, especially in asthmatics. Theophylline is more potent than caffeine. It has slow and sustained dose-related bronchodilation. It is produced, but the effect is much less marked as compared to inhaled beta-2 agonists. On kidney, methylxanthines are mild diuretics. They act by inhibiting the reabsorption of sodium and water. In addition, the vascular effects may result in increased renal blood flow and glomerular filtration rate. Theophylline is more potent, but action is brief. On skeletal muscle, caffeine enhances contractile power of skeletal muscles. At high concentration, it increases release of calcium from sarcoplasmic reticulum by its direct action. Now, the adverse effects are, it has a narrow margin of safety. Dose-dependent toxicity starts from the upper part of therapeutic concentration range. Adverse effects are primarily referable to GIT, CNS, and CVS. Children are more liable to develop CNS toxicity. The toxicity level is shown in this diagram. First, minimal side effect, and if the dose is increased, it may lead to death with several symptoms. Uses: bronchial asthma, COPD, apnea in premature infants, short-acting beta-2 agonist, albuterol, 2 puffs every 4 hours inhaled as needed are the drug of choice for relieving acute bronchoconstriction and preventing exercise-induced asthma. They should not be used alone for long-term maintenance of chronic asthma. Now, what is COPD? It is a progressive disease with emphysema, that is alveolar destruction, bronchial fibrosis in variable proportions. The expiratory airflow limitation does not fluctuate markedly over a long period of time, but there are exacerbations precipitated by respiratory infections, pollutants, etc. It is clearly related to smoking and characteristically start after the age of 40. If we quit smoke, it reduces the rate of death and lung infections. Patients derive less than 15% improvement in forced expiratory volume in 1 second following inhalation of beta-2 agonist bronchodilator. Airway obstruction is largely irreversible. Now, next, the long-acting beta-2 agonists are superior to short-acting ones and are equivalent to inhaled anticholinergics in COPD. They reduces breathlessness by abolishing the reversible component of airway obstruction. Theophylline benefits by causing bronchodilation as well as by decreasing the release of inflammatory mediators. They improve mucociliary clearance, stimulation of respiratory drive, and by augmenting diaphragmatic contractility. However, because of narrow margin of safety and limited efficacy, its use has declined. Next, the inhaled ipratropium or tiotropium are the bronchodilators which are used in COPD. Because they produce slower response than inhaled sympathomimetics and they are better suited for regular prophylactic use, it is used in 2 to 4 puffs 6 hourly or tiotropium. 1 rotacap OD than for control of an acute attack. The drugs are: oral theophylline can be used in mild to moderate severe asthma as a third line or alternative adjuvant drug, especially in patients with nocturnal asthma. It is more useful in COPD. A short course, 1 to 3 weeks of oral glucocorticoid, may benefit in some patients of COPD during an exacerbation. High-dose inhaled steroids are beneficial only in advanced COPD. With frequent exacerbations, they should not be used in early or mild cases. There is no proof that they slow disease progression. The adverse effects are acidosis. Next one is adjuvant antitussive bronchodilators, salbutamol and terbutaline are used. Expectorants, mucokinetics are the drugs which are believed to increase bronchial secretion or reduce its viscosity, facilitating its removal by coughing. Sodium and potassium citrate are considered to increase bronchial secretion by salt action. Potassium iodide is secreted by bronchial glands and can irritate the airway mucosa. Prolonged use can affect thyroid function and can produce iodes. Expectorants are rarely used now. Guaifenesin, Vasaka, balsam of Tolu are the plant products which are supposed to enhance bronchial secretion and mucociliary function while being secreted by tracheobronchial glands. Bromhexin, a derivative of alkaloid vesicin, is obtained from Atheroda vesica. It is a potent mucolytic and mucokinetic which is capable of inducing thin copious bronchial secretion. Thank you.